Kajit, nice to be with us. Professor Kajit Flatmark, you are a surgeon in Oslo, in Norway, and you are a surgeon. You make operation, but you are the responsible for a research unit, and you drive the research unit. So, is it difficult to do the two works? Is it important for a surgeon to be implicated in research?
I started doing research relatively late in my surgical career. I'd been a surgeon for 10 years. And so that's when I started my PhD. And I think that doing research in parallel with surgery, so I do 50% research and 50% surgery. And 50 plus 50 is probably 150, I think, generally, which you probably know. I think that makes it much easier to understand many of the processes that we study. It makes it easier to understand why the patients are not cured always, and it makes it easier to find good strategies to make new studies, to think of new trial designs, to know how to biobank, for instance, and that's the good part of doing this combination. The challenging part is that you risk being a not so good surgeon and a not so good researcher because you're not completely dedicated to one of the parts of the work. I think that's a risk, but I think it's very important that some of us actually do this and do both. I don't think everybody should do that. I think everybody should do a little bit of both, but I think we really need also in university centers surgeons that are dedicated surgeons, and we need some that go all the way into research, but we also need a few that do everything.
So different profile for the surgeon because there is different things to do.
Yes, I agree.
Okay. So we have to, all the surgeons have to look about research a little to know what happens.
Yes.
Okay.
I think that's important.
And my second question is regarding your country. You live in a beautiful country, but this is a very big country, and there is only one center, an anti-cancer center in Norway, is on Oslo. How did you organize when a patient have a disease, a peritoneal disease, like by example a pseudomyxoma? Did you see the patient, or did you speak with the doctors that take care of it? How did you organize the cares of the patient in Norway?
Norway is a very long country, but we only have 5 million inhabitants. So there aren't that many patients to treat, for instance, for pseudomyxoma peritoneae. We have maybe like between 5 and 10 cases a year. So this means that many of our patients have to travel far to come to treatment. And we generally, both for pseudomyxoma and for peritoneal carcinomatosis, we don't see our patients until we have evaluated their medical history, their extent of disease that are sent to us. And we also generally see many CT scans during and after medical treatment, chemotherapy, for instance. So mostly we don't see our patients until we know that we have surgical treatment to offer them.
So you take times, but times with CT scan before you see the patient. And if on the CT scan, or if it's occlusion or ascites for a colon carcinomatosis, you don't see the patient, and you explain to the doctors that they have to take care, but differently.
Every week we have multidisciplinary meetings where we have surgeons, oncologists, radiologists, and sometimes pathologists who discuss and look at the images, look at the medical history and discuss what is the best strategy for this particular patient. And then after every meeting, we write a report that is sent to the referring hospital, and then with our decision, and then they will take care of the patient if we don't have any treatment to offer. They may have just palliative chemotherapy, for instance, and otherwise we take them for us to see them before we do surgery.
And for 5 million of people, you have one center.
Yes.
Is it enough, or did you think that a second center could be interesting for the number of patients, but maybe there are other places in Norway that met IPEC, by example, or there is only one place?
There's only one center that does HIPEC in Norway, and also this extensive site reductive surgery. Presently, we do we evaluate maybe 150 patients a year in our meetings. We do a laparotomy on maybe 75 patients, and we have last year we did full site reductive surgery and HIPEC for 50 patients. So this means like one and a half a week, every week, if you calculate 40 working weeks. And so this is a number that we can handle.
And did you see the last years an increase of patients that refer for peritoneal disease?
Dramatic increase during the last 3 to 4 years.
So if it's increased more, you need a second center?
I think so. And one of the things that we're discussing quite extensively is whether patients with ovarian cancer also should have HIPEC.
Yeah.
And if we are to include HIPEC for a number of ovarian carcinoma patients, I think the number will increase quite a bit. So then we either would have to expand and become a much larger center, or there would have to be another center in Norway, I think.
So it means that actually for Norway, the indication for IPEC are colon cancer, appendiceal cancer, mesothelioma, pseudomyxoma, and it's only.
Yes.
So it means that if the SHIPOR project in France, but I know that there are other trials in other way, prove that you have to propose that for ovarian cancer.
Yes.
One case, one surgical unit for 5 million is not enough?
I don't think so.
Okay.
I don't think so.
So we have to wait the result of the randomized trial.
And of course, we would have to establish the methodology, and that would be done in our center. But then we would see probably after a while, when more and more patients see that, okay, this is an option, then I think we would have too many patients.
Okay.
I think so.
So wait for the future.
Yes.
Thank you. Thank you, Professor
Yeah.
Flatmark. Thank you.